Uh, Today sounds like it's raining outside. A lot of thunderstorms. Can you guys hear that? Yeah. Don't you think it's a perfect time for us to talk about storms? I think so. What do you think? Why don't we talk about thyroid storms? Look at that. We will be talking about thyroid storm actually. So, what exactly is thyroid storm? Let's look at the definition. Thyroid storm. Something must have been happening to the thyroid gland. It's going out of whack. So we're going to start with the definition. This is a decompensated state of thyroid hormone induced severe hypermetabolism. Oh, that's a big mouthful. Let's put it on the board. Definition. Basically, thyroid hormone gone wild. All right? The thyroid gland gone wild. Can you imagine? It's a state of hypermetabolism. Can you imagine? The thyroid gland, as you can see, it's not looking too cute on this right side. Can you see that? It's got the devil face. It looks like it's sweating. And guess what? It's spitting out a lot of stuff. A lot of T4, levothyroxine, and triiodothyroxine. It's not too happy. Well, this is called an extreme case of thyrotoxicosis. Extreme case. And we're talking about thyrotoxicosis. Let's break the word. Thyroid toxic. This is an extreme amount, massive amount of thyroid hormone being pumped into the circulation. It's like somebody taking a machine gun and just spraying. No destination, just keep hitting anything you want. Well, the patient is going to be the one who's going to have to suffer for this. Normally, patients with thyrotoxicosis either have a history of hyperthyroidism. You have a history of hyperthyroidism. What is hyperthyroidism? That means the thyroid gland is cranking up a lot of T4s and T3s, which means my TSH, my thyroid stimulating hormone, is going to be low, because if I'm making too much down here, I'm going to tell my pituitary, hey, don't worry, I got this, shut up, don't tell me what to do, right? So these patients normally have elevated amount of T4s, T3s, and low TSH. However, they always present with what? Heat intolerance. Heat intolerance. And they're always sweating. They're always sweating. These patients are always sweating. They're like, Doc, I'm always hot all the time. Not kind of like sexy hot at the beach. No, they're always hot. And then they're sweating their balls out. But the problem is, when they go nuts, when this thyroid gland goes nuts, now they're going to develop a fever. They're going to become hyperpyrexic. When they decide to go into the rain and it starts raining, we're going to develop hyperpyrexia. What does that mean? Elevated amount of body temperature. They have a fever, massive fever, over almost 38.5, and they can go all the way to 41 degrees. That is ridiculous. Your body can't function at this kind of temperature, don't you think? No. But here's the catch. Their state of hypermetabolism from their what? Thyrotoxicosis, because the thyroid gland is now working overtime and doing more than it's supposed to do, will lead to increase in oxygen and energy consumption, right? What is metabolism? Remember, we're using glucose. Glucose is going to be broken down, eventually making a DH through the what? Into the electron chain transport, cranking up a lot of what? ATP. We're going to be using the oxygen to do what? To catalyze that reaction. So when thyroid gland is causing too much metabolism, we're going to be wasting and using up a lot of energy, ATP, right? That is the key energy key in our body, is ATP. Now, because this is happening massive, right? Imagine standing in the rain. just not your little forehead is gonna get wet, right? The entire body from head to toe is gonna get wet, don't you think? So that's why on the right side of the board, we're gonna talk about what part of the body is gonna be affected the most when there's a thyroid storm. But before that, wouldn't it be nice to kind of know what the pathophysiology of thyroid storm is? I think so too. Now, the pathophysiology of thyroid storm, it's actually not fully understood. Now, there's hypotheses and theories that explain what the pathophysiology really is. However, pathophysiology. One proposed mechanism of thyroid storm pathophysiology is that these patients have elevated amount of thyroid hormone, a lot more than people that have uncomplicated thyrotoxicosis. That's one proposed theory. We don't fully understand this, but another theory also states that these patients actually have increased adrenergic receptor activation, because the sympathetic nerves, I'm just using as a line here, right? Sympathetic nerves feed and innervate the thyroid gland, which cause the thyroid gland to crank up and produce a lot of T4s and T3s, which is now going to increase beta cell receptor activation, so that these patients have a lot more beta 1, beta 2 receptors being activated all over their body. And when this is activated, guess what happens? When norepinephrine binds to them, you get more catastrophic effects. These are just theories. But the bottom line is, these patients have elevated amount of metabolism, increased use of oxygen and what? Energy. So they might either have a lot of thyroid hormone being produced, which is relatively higher than most patients, or they have what? Beta cell receptor activation. This is usually supported by the theory that patients that use pseudoephedrine, right, which is an adrenergic receptor agonist, does have what? Increased propensity to develop thyrotoxicosis. On the other hand of things, we're actually going to get a lot more from their history, which is non-specific, so you really have to be very, very suspicious of this patient having thyroid toxicosis. So let's take a look at what these patients are going to present with on history. These patients might actually have a history of thyrotoxicosis. They might have had this in the past. They might tell you, well, I've had this actually happen to me in the past. Then that is a good thing. But if they don't have this, they're going to come in with all this sort of complaint that is basically non-specific, because this can be a differential diagnosis on its own. They're going to have neurologic problems. So we're going to use that as an N in the brain. They're going to have heart problems, and we're going to have GI problems. Now, usually these patients are going to come in with anxiety. They're nervous, right? They might have seizures, right? They might be shaking. It depends on what kind of seizure they have, right? They might have tremors. Now, this is all from what? The beta adrenergic receptor activation, agitation, confusion. Think about it. When you're nervous, how do you look? You don't look cool, right? You're nervous, you're shaking, you're agitated, your heart is racing, you're getting palpitations. That's exactly what these patients are going through. They have a thyroid storm. It's spitting out the T4s and T3s, increasing metabolism. They already have heat intolerance, right? They also already have diaphoretic because they're sweating. See those little sweat drops? Exactly. But plus, they're having massive fever. So you're having a fever, and you're nervous, you're having anxiety, you're irritable. These patients can actually go into coma. That is not a good sign. They can go into coma, but typically they might also report that they're having a voracious appetite. Voracious appetite. They're eating everything under the sun, But guess what? They're not gaining weight because once they eat it, they burn it. They eat it, they burn it. They really have massive appetite. But they can also have poor performance in school. The problems with attention. They can't pay attention. Poor attention span. These patients are miserable. Now, what general symptoms can they develop aside from the top, right? We're starting from the head. Well, let's look at the heart. What is the effect of T4s and T3 on the heart? Remember, it activates what? Beta adrenergic receptors, which is on the heart. Which one are those? Beta 1. If that increases beta 1 activation, they're going to develop hypertension. Because the heart, the systemic vasculation is what? It's vasoconstricting. Increases their preload, increases their afterload, increases their cardiac output. Eventually, they develop hypertension. These patients also, their heart, they develop heart failure because their heart is trying to contract as fast as they can. Eventually, it can't anymore. They develop signs and symptoms of heart failure. They can actually develop pulmonary edema because of the blood is backing up into the lungs. Because of the increased heart rate, right? This patient is going to have tachycardia, right? They're going to have tachycardia. It could be just sinus tach, but eventually can progress to supraventricular arrhythmias. Oh, that's a big word for what? What is supra? Supra means above, right? So here's the ventricle department, and anything above the ventricle, we name it supraventricular. Supra means above the ventricle. Anything that's happening above the ventricle, it's called supraventricular arrhythmia. What's going to be, which part of the heart are we talking about? We're talking about the atrium. We're talking about the atrium. Which specific arrhythmia? Atrial fibrillation. You have to remember that. Atrial fibrillation. One of the most common cause. One of the most common arrhythmias if a patient is having a thyroid storm. They can have A flutter too. See, also it's another AF. Rarely they might develop ventricular tachycardia, but atrial fib, remember that atrial fibrillation is what they're most likely predisposed to because their heart rate is going really, really, really fast. This is all the side effects of the T4s and T3 thyroid hormone on the heart. Now, your heart is racing, right? You're nervous, you're anxious, you're also agitated. You might be having some seizures, you might have some tremors. Then guess what comes with it? Your GI start to act up. That is when the stomach and the intestines say, guess what? Hey, we're going to get affected too because they're sympathetics to your what? To your gut. Parasympathetics allow you to what? Sympathetics are going to cause you to develop what? Nausea, vomiting, diarrhea, right? Abdominal pain, jaundice. These are general symptoms, all from the side effect of what? Thyroid storm, plus the fever. So, these patients are very, very miserable. Now, physical exam, obviously you're going to notice these patients have a fever like we talked about. They're going to be sweaty, right? You can see their heart rate going up. They might have signs of heart failure. These are the things you want to keep an eye on. And look for orbital signs, right? Because we haven't talked about what causes this, right? Look for orbital signs. Because these patients might have Graves' disease. And also look for signs of goiter in their neck. A big, massive, swollen goiter. So that's going to bring us to what might actually cause these patients to develop a thyroid storm. Well, we said they might have a history of what? Hyperthyroidism. But specifically caused by Graves' disease. Well, let's talk about Graves' disease. Graves' disease is when you have thyroid stimulating immunoglobulins. Immunoglobulins, right? They're these little Y-shaped objects. They're going in and they're binding and telling the thyroid gland, make more, crank up a lot of T4s, crank a lot of T3s, right? They're not going to listen to your pituitary anymore because these are autoimmune activation. So these patients might have a history of what? Of Graves' disease. They might also have, but most importantly, usually what activates this is usually stress. Let's talk about stress. What kind of stress are we talking about? If these patients have a stress reaction from either sepsis, right? Surgery. After a surgical procedure, this patient might just have anesthesia. Induction. Surgery, sepsis, anesthesia, drugs, medications. They might be diabetic and have DKA. Drugs like anticholinergics. These are all the things that can tip them off the what? That hyperthyroid state into the super hyperthyroid state. That's how I remember thyroid storm. It's the super hyperthyroid state. Also from direct trauma to the thyroid gland, right? If I damage your thyroid gland by banging on it, don't do that, right? You can develop a thyroid storm because you just shoot up a lot of what? Thyroid hormone up into your bloodstream. That might not be good. So, also this can happen in children. I have to let you know that. This can happen in children. However, it's usually the children will have what? Graves' disease is usually associated with Graves' disease. Also, the patient mom from pregnant woman. That's a pregnant woman with a little baby inside of his belly. Pregnant woman that can transfer the thyroid stimulating immunoglobulin that's sneaking through the placenta wall. These are the thyroid immunoglobulin, and this is the placenta, and this is the baby. Okay, they sneak in through the placenta wall and affect the baby, and then the babies can also develop thyroid storm. So you want to remember that. So these are the different things that can cause patients to develop thyroid storm. We've talked about what we're going to see on history and physical exam. How do we make the diagnosis of thyroid storm? This is purely a clinical diagnosis. You just have to clinically be able to put this whole story together from the history, physical exam. However, what labs can we really order that might give us any clue at all? Well, we can just get Thyroid Studies to see what it tells us. And this Thyroid Study is just going to show as if they have hyperthyroidism, which they will have increased T4 and T3 and a low thyroid stimulating hormone levels. So, sounds like they're hyperthyroid, but remember they're super hyperthyroid. Also, you might order a CBC, but when you get a CBC, you might see some leukocytosis with some mild left shift. Mild white count with a small left shift. But this is very non-specific. It's because their body is really under a lot of stress, and they're cranking up all these leukocytes, popping them away from the endothelial wall, because that's what happens when you're under stress. If I stress you out right now, your white count is going to go up. And that's basically why they have a mild leukocytosis. You might see some changes in the LFTs. You might see some increased non-specific alkaline AST and ALT levels. You might see also some elevated amount of LDH and creatinine, but these are all non-specific. It's not telling us anything spectacular, to be quite honest with you. You might see some elevated amount of bilirubin. Remember I told you they're all jaundice? Bilirubin. So what imaging are we going to get? Well, in terms of imaging, remember their heart is beating really fast, so it might be nice to kind of get a chest x-ray. The chest x-ray might show us signs of CHF, massive heart, dilated, right? Big heart, but it's not that strong. You might see some pulmonary edema on the chest x-ray that may show signs of what? Congestive heart failure. You want to order an EKG because these patients have what? Atrial fibrillation. And when you see that irregular with no P waves, that's telling you they have atrial fibrillation. That's the only thing so that we can be able to pick up their cardiac arrhythmia and be able to treat it accordingly. However, there's really no specific test that will be able to tell us you actually have thyroid storm. Wouldn't it be nice to know how we're going to treat them? Yeah, I think so too. So how do we treat thyroid storm? Well, we're going to treat them first. We're going to start with beta blockers. Now, beta blockers, their job is actually to prevent the peripheral conversion of T4 to T3. You can give this patient propranolol, which is going to have an effect on the heart to decrease the blood pressure, right? To decrease the heart rate, decrease contractility on the heart. But most importantly, beta blockers are going to block what? Beta blockers are going to block conversion of T4 to T3 peripherally. So you want to remember that in the peripheral tissues, you don't want T4 to be broken down into T3 to have more effect on the peripheral tissues. After using beta blocker, we can also give them anti-thyroid medications. Anti-thyroid meds. Which meds are we talking about? Well, we only have two. PTU. What is PTU? Propyl thiouracil. And our favorite other guy, methimazole. Now, PTU prevents organification of and trapping of iodide and also inhibits coupling of the iodotyroxines. Now, if you don't understand that, you have to go back to our thyroid lecture and you see the entire pathway of organification pathway, iodification pathway, and see how MIT-DIT, which is monoiodothyroxine, and dihydrothyroxine is being made inside the thyroid gland. But the job of PTU is to prevent that reaction from occurring. Because now if we can make T4 and T3 by the thyroid gland, then we can't have any T4, T3 in the circulation. It can't have any effect at all. Also, the good thing about PTU is it inhibits peripheral conversion. PTU acts on this pathway and prevents T4 from being broken down into T3. Plus, decrease organification, trapping of iodide inside the thyroid gland, because we need iodine to be able to make thyroid hormone. Methimazole also is very important because it also prevents organification and trapping of iodides. Now, we need to talk about all the medications that we can use to also treat thyroid storm. Well, we can also give these patients glucocorticoids. Well, glucocorticoids are good because they decrease peripheral conversion of T4s to T3s. So they are very good to be able to prevent the transformation of T4s to T3s. You can also give these patients iodides. Iodides such as potassium iodide or just iodides on its own. And iodide's job, the function is to inhibit the release of thyroid hormone from the thyroid gland. Inhibit the release of thyroid hormone from the thyroid gland. So as you can see, we've used multiple medications to be able to control this patient's symptoms. Well, if they have a fever, wouldn't it be nice to give them an antipyretic? Yes. You can give them acetaminophen, Tylenol, right, to bring down their fever. Now, because they're having massive diarrhea or nausea and vomiting, you probably want to give them something for their nausea and their vomiting, and give them some IV fluids for their what? For the diarrhea, because you do not want these patients to be massively dehydrated. So these patients need supportive therapy. Hey, thank you so much for watching the video. I hope you learned a lot. Are you studying for the USMLE Step 1 or Step 2? Are you studying for the NCLEX, or you're currently in nursing school as a nursing student? Are you a PA student currently in school or studying for your PANCE exam? Or are you a nurse practitioner student or trying to take your NP board exam? Listen, I've got super awesome content for you. If you truly love this video and it simplified your learning process, I want you to check out my website below. I've listed all the list of exams, whether you're studying for any of this board exam, and all I want you to do is click on the link right now below so that you can take you directly to my website. For USMLE, just go to smashusmle.com. For NCLEX, go to crushnclex.com. And if you're studying for the PANCE exam, the nurse practitioner exam, or you're studying for your internal medicine board exam, just click below and it'll take you directly to ftplectures.com. Listen, I can't wait to help you. If you need to get in touch with me, just get to my website, be able to reach me directly, and we can work together one-on-one. Listen, you're super awesome, and my goal here is to help your dream come true. If you want to be a doctor, want to be a nurse practitioner, a registered nurse, or physician assistant, I'm here to help you get to that next level. With your medical knowledge, let's save the world together. I love you guys. You guys are super awesome, and do not forget to click on the link below to be able to get to my website. Also, don't forget to subscribe to my channel. You guys have a great day. Let's go.